Good morning, everyone. Thank you so much for joining us today. We are waiting on a few more participants to join us here on Zoom. Thank you for your patience. We'll get started here in a few minutes. Hello, everyone. We are now ready to get started. Commissioners, I'm turning on your audio and your video.
Good morning, everybody. It is a pleasure to see you all again, and welcome. This is the May 13th, 2021 meeting of the Little Hoover Commission, the public hearing on COVID-19 and children's mental health. I'm Pedro Nava, and I'm the chairman of the Little Hoover Commission. Thank you again for joining us today. I want to introduce the other commissioners who are with us on Zoom. Joining us is Vice Chair Sean Varner, Commissioners Dion Ehrener, David Beyer, Cynthia Buisa, Bill Emerson, Kathy Schwamberger, and Yana Sidney. It is my understanding that we can expect Senator Jim Nielsen and Assemblymember Bill Quirk to join us as the meeting proceeds. Also with us today are members of the Commission staff, Executive Director Ethan Rarick, Project Managers Crystal Beckham, Tristan Stein, Analyst Ashley Hurley, and Rachel Mattioli. Let's do some housekeeping before we turn to the subject at hand. Commissioners' audio and video will be turned on throughout the duration of this hearing. Commissioners, you may mute yourself if you wish. Please remember to unmute yourself if you want to make a comment or ask a question during the hearing. And as is my practice, I will scan over your screen to see if a commissioner is unmuted, and I will take that to mean that you wish to make a comment. The video and audio of our hearing witnesses will be turned on when it is their opportunity to speak. Members of the public will be muted during the hearing. As is standard for the commission, we will have a public comment session at the end. Those who wish to make a comment will be unmuted during the public comment session at the end of the hearing. If you'd like to make a public comment, please use the raise hand feature in Zoom by clicking on the hand icon to join our public comment queue. There will be those who will join by phone. You may send an email to littlehoover@lhc.ca.gov as reflected on the screen, indicating that you want to address the commission. Please provide your phone number from which you have joined the meeting so that our staff knows who to unmute. Staff will be monitoring raised hands and emails requesting comment throughout the duration of our hearing. As is usual at commission hearings, public comment is limited to 3 minutes per speaker. We are recording today's hearing, and after the meeting, staff will place a permanent link to the recording on our website and upload it to our YouTube channel. And now to the substance of today's hearing. This is the second of 3 commission hearings on the COVID-19 pandemic's impact on children's mental and emotional well-being. In the previous hearing, we heard from child mental health advocates and experts in mental health policy who spoke to the state of children's mental health in California, COVID's impact on child mental health, and steps that the state can take to better support young people's mental and well-being. And we're going to be hearing from witnesses who will speak to COVID's impact on children's mental health from the perspective of local institutions and agencies that deliver child mental health services and help to support children's mental well-being. Today's witnesses will speak to the ways in which children's hospitals, community organizations, school districts, and county school systems of mental health are working to address children's mental health needs. In 2 weeks, we will hold our final hearing on this topic, during which we will hear from state agencies responsible for supporting child well-being and mental health services. I'm pleased to announce that the witnesses testifying at that hearing are scheduled to be Dr. Mark Galley, Secretary of the California Health and Human Services Agency, Dr. Nadine Burke-Harris, the Surgeon General of California, and Toby Ewing, the Executive Director of the Mental Health Services Oversight and Accountability Commission. But today we look forward to hearing local level perspectives regarding COVID's impact on children's mental health and what California can do to better support children's mental and emotional well-being. And I have to say that we have staff has lined up an impressive list of witnesses who have, for that trite saying, boots on the ground with respect to working with organizations, funding streams especially, and children who need help. In reviewing what we're going to do today, it sort of struck me that it is an opportunity because we all know that the issue of mental health is one that is not well received by most of the public. If you have a physical ailment, nobody criticizes you when you go get care and treatment for it. But there is still a stigma associated with getting treatment for mental health. And I'm encouraged by what these organizations are doing, and also by the fact that you're going to have a generation who, because of the COVID, will have exposure to a treatment and care and a different vocabulary, I think, for providing help to people who have difficulties and challenges with mental health. So enough of editorializing. Now, let me ask the project manager for this hearing, Tristan Stein, to please introduce the first witnesses.
Thank you, Chairman Nava. Our first witness this morning is Dr. Brian Distalberg. Dr. Distelberg is a professor of counseling and family services in the School of Behavioral Health at Loma Linda University and the director of research for the Loma Linda University Behavioral Medicine Center. In addition, he is director of Loma Linda's MIND, Mastering Each New Direction program, which addresses physical health and chronic physical health challenges through behavioral health integration. Dr. Distelberg is also leading multiple research projects focused on integration of physical and mental health. Dr. Distelberg was scheduled to appear with his colleague from Loma Linda University Children's Hospital, Dr. Amy Young. Unfortunately, Dr. Young is unable to testify due to an unavoidable last-minute scheduling conflict. Dr. Distelberg, we are sorry that Dr. Young is unable to join you, but we very much look forward to your testimony. Please.
Dr. Distelberg, this is Pedro Nava. Before you launch into your testimony, I just have to say, I grew up in San Bernardino and in Fontana, California. My mother received medical care at the Loma Linda facilities. And you have an extraordinary reputation for providing health care, for being sensitive, and it is really, truly an honor to have you here today.
Oh, thank you so much. We are very much honored to be with you today and provide some perspective from our area, from our community, and some of the struggles that we're having, but also some of the unique opportunities that we're seeing come out from kind of the backside of the pandemic that we're in right now. And as you mentioned, I am from Loma Linda University, and that is a significant hospital facility for Southern California, serving both San Bernardino and Riverside County, as well as outstretching counties from those areas. We are also a university, and we take our mission very seriously. We're very passionate about serving our community, and that drives everything we do, including how we have managed through this crisis that we've gone through in the last 12 plus months, trying to get through the COVID process. I want to just point back to part one of the testimonies, and a lot of great things were said in part one, and I would just echo everything that was said there. Dr. Insel has a wonderful perspective on where behavioral health was pre-pandemic and some of the solutions going forward. So I won't spend time reiterating what he and the rest of the panelists said in that last testimony because we just simply agree with it. It's been a challenge. What I would do is come at this issue from our unique perspective, which is from a hospital perspective. And we provide, yes, hospital care for youth, but we also are one of very few inpatient behavioral health hospitals for youth in California. There are not that many. We happen to be one here that's serving San Bernardino and Riverside County. We also receive patients from LA, Orange County, and beyond. And patients do travel quite a ways to have to get to behavioral health care. So from that perspective, I want to just pick up on a couple of things that were happening pre-pandemic that maybe weren't highlighted as much because a lot of what was talked about in the last testimony was a lot of the downstream preventative stuff, which we fully support. We think that is a way to solve a lot of the problems that I'm going to talk about today, which is, first of all, prior to 2007, youth suicide rates remained pretty stable and low. However, between 2007 and 2017, those rates increased by 56%. Most concerning, the youth suicide rates have been rising almost 7% every year since 2013. So we were losing this battle against youth suicide rates in California and nationally. For depression rates, those also rise at the same rate as that. So between like 2004 to 2007, youth depression rates in California were at about 8.1%, which is a lower number than what others have said. And what I am talking about is actual episodes of depression that resulted in the need for care. So it's a little bit more severe designation. If you're in the 8.1% that I'm talking about, you definitely were going to be encountering behavioral health services. So prior to 2007, it was about 8.1. Between 2016 and 2019, that raised to 14.1%. So we're almost doubling on our depression rates for kids as well. So we had a significant problem going on with youth behavioral health prior to the pandemic. And then on top of that, the resources that we have to serve those needs pre-pandemic were tight. From the California Hospital Association survey, we know that we were short inpatient beds for youth in California. SAMHSA has done a survey to determine how many behavioral health inpatient beds would be useful for a community. And they recommend a pretty high number, which is 1 bed to every 2,000 residents in a community. We are not even close to that in California. We are at 1 bed to every 5,834 individuals. So we're not even 50% of where we should be in terms of the number of inpatient beds we should be having for a community our size. So we were struggling pre-pandemic, and that got really worse during the pandemic. What happened during the pandemic time is that we saw increases in the needs for kids. Depression rates went higher. Suicide, self-injury rates went higher. The beds shut down in some cases because for our facility, we were lucky. We didn't have to shut down much. And I think we only for kids had to do it once. But anytime somebody ended up in an inpatient facility, the standard operating procedure is if they landed there and they tested positive for COVID or some other patient tested positive for COVID, either there or shortly after discharge, the units or the associated beds had to be shut down and gone through a protocol to clean and reopen. So we were already very, very tight beds. And then we had to take beds offline from time to time to deal with that, which made a really bad situation worse. The result of that is what we call ED boarding. And what that means is that across California and across the nation, really, you have kids that are showing up in the ED for significant severe behavioral health needs. They're not able to move out of the ED because you don't move kids out of the ED when they're in a severe crisis unless you have a place to send them that is going to be able to care for them. So currently we have a situation going on where kids with behavioral health needs are staying in an emergency department for upwards of 10 to 15 days. And the reason for that is that there are not beds to send them to, like inpatient beds. That's one issue. The other issue is that we're not doing a super great job doing crisis reduction in ED areas. So if we are able to invest in crisis reduction care in ED situations, what that'll mean for this problem is we'll be able to move kids from ED to lower levels of care. So they won't necessarily have to go from an ED to a behavioral health inpatient bed. They can bypass that step and go to the other levels of care, which have greater capacity, but they are still struggling as well in the state. One of the unique things that I would say about what's happening here in San Bernardino is that we have been partnering with our Medi-Cal community provider that's for us locally, that's IHP or the Inland Empire Health Plan. Up until about, I think it was 2012, if you were a youth that had Medi-Cal insurance, your options for behavioral health care were quite limited. You could have access to inpatient levels of care, but anything lower level than that was being routed back to DBH-oriented services, which are, those resources are very, very tight and they're very hard to get into. At about 2010, we ran a pilot with IHP to allow IHP to provide services for their Medi-Cal IHP population back to Loma Linda. We did that in one very specific program that was for kids that had both a physical health condition and a mental health condition. And that program went very well in that the kids got services quickly, they got better, and they didn't have high recidivism rates back into ED and inpatient stays. And because of that, IHP decided to allow access to partial hospitalization intensive outpatient for all of our kids here who have that combined Medi-Cal IHP status. I think that is unique here, and we're seeing great rewards and great benefits from that. We're getting a lot of kids services that otherwise would be stuck in kind of complicated behavioral health systems that the state has set up. I think one of the comments from the first testimony was kind of siloed ideas of behavioral health, not only between all 58 counties and 60 different providers, that those are disjointed, but even within a county, the services are disjointed because different levels of behavioral health care get allocated to different resources. And it's very complicated for a patient to understand that. It's very complicated for providers who are professionals in this to actually execute that complicated process. But we have shown here locally with our partnership with IHP that in that kind of setup, it does work very well, and we can provide really great care. And we're reducing recidivism into our inpatient and into our ED. We still have the issue of, even though we are doing that, we have significant overburdening on the ED because kids are coming in more and more for self-injury or significant depression episodes, violent episodes, and they end up being routed to the ED first. And if there's not enough beds to send those kids to, they end up staying there and creating quite a bottleneck. There's also an effect of the kids being out of school. School has a lot of beneficial effects. One of those effects is early identification of needs so that those needs can be met before a kid ends up in a crisis and needing to go to an ED. That's one issue. Schools were also likely to identify kids and bring to the ED. So that's not happening as much. And so when the kids are coming to the ED, it's because they're being identified in other areas, which means that they're very, very severe. The other side effect of schools is that the kids were getting social support, social connection, all of this great, wonderful community interaction through schools. They're not getting that now. And we actually have kids that schedule with each other to go into the ED together because it would be a time that they could be together as friends. And that is very, very problematic. That is not an effect of not enough beds and resources. That is an effect of our kids are struggling because they don't have community support that they were dependent on pre-pandemic. Yes.
Yeah, I'm going to interrupt, and let me apologize to you because, and I explain this to witnesses often. When we interrupt, you should feel a compliment because that means commissioners are responding to something that you have said. And I really do appreciate the way that you are presenting because you're covering a great deal of area quickly. But David Byer has a comment or a question.
Wonderful.
Thank you, Mr. Chairman, and thank you for your testimony. We, the Little Hoover Commission, has been on the subject of mental health for a number of years. And the question is, to address your point about 57 plus counties and multiple jurisdictions and complexity. But the base is an expectation that on Friday, that's tomorrow, the governor will announce a $3.5 billion infusion of money into the mental health systems of California. My question is not whether that's a good thing, that's an unalloyed good thing, but we've seen infusions of money in the past. And my question is there a structural gap in the mental health treatment in California that is a product of failing to have a single person or authority to coordinate mental health care within the state. In other words, there is a Secretary of Health and Human Services, but there's no one who's in charge of mental health to coordinate between the counties, the providers, the managed care organizations, and the structure that's been set up seems to be deficient, and that's been the conclusion of the Little Hoover Commission in our past reports. What are your views?
Yes, I would echo that from our point of view. The services are disjointed across counties. It's very hard for us serving 2 counties. Every county behavioral health service comes with a ton of paperwork, ton of regulation, and when you have to do that across 2 counties, we spend way too much of our precious behavioral health resources on trying to navigate these systems. It's not fair for the patients, and it overburdens the systems that are trying to provide care. So a centralized leadership, going back to maybe what it was before, but with maybe some updates from what we've learned, I think would be very useful. Another way to centralize is through, we're very excited about what we're hearing in terms of CalAIM. We think that will be very useful. And one of the ideas in CalAIM that we're very excited about is more involvement from the MCPs in terms of the behavioral health orientations. Again, that we've been piloting that here with our MCP, and it's working wonderfully. There's still regulation, and there should be, it's healthcare, but there's a lot less, and the patients are getting better access, quicker access to higher quality care. And if we can do that, I believe there's only 26 MCPs in the state of California. If we even just made that pivot, you're taking complicated 60 different systems down to maybe 26. I think that would be very useful. But yes, a centralized state level, I think there is a lack of leadership there. And I heard in the last testimony, one of the things that I would echo again, the outcomes issue. Behavioral health as a system and as an industry is starting to get better at doing outcomes. And a lot of what could be useful in terms of bringing this industry into the next cutting edge is making reimbursement dependent on outcomes. And the state of California actually just produced a fairly significant funding source that we were able to participate in. And I think there's a bunch of others participating in, and that is funding through Prop 56 money. And that came through DHCS, it's a Behavioral Health Integration Initiative program. That's a significant source of funding that's trying to help fee-for-service organizations like Loma Linda take some of the lessons learned from FQHCs. FQHCs have ability to tap into funding that allows for behavioral health integration. Behavioral health integration is really the solution to what we need to do in behavioral health. I've been talking about beds and all of that, and we do need more beds, but one of the things that would help, even if we can't get more beds, even if we do get more beds, we still need to do it. We need to be better on the front end. We need to be better at identifying things earlier on before they raise to the level where a kid has to be sent to the ED. One of the ways to do that, which was talked about at length in the last testimony, was some of the community-based processes, some of the school-based processes. We're really excited about integrating into our healthcare system. So when you have primary care that's working side by side with behavioral health, we can identify behavioral health issues in kids at their annual exam when they're light touch issues that can be solved at that level and not have to take costly approaches like going into ED for 3 to 5 to 10 days and then inpatient for another whatever days and then all the way down the continuum. So if a centralized leadership can help push this industry to achieve those things, I think that would be great.
I have a question and see whether or not you can answer depending on your experience with administrative. I'm interested in what sort of accommodations an organization like yours had to make in order to keep track of all the different funding streams, regulations, and reporting requirements. So did you have to commit, one staff person to try to corral all of this? Is it more than one person? Do you have an estimate as to how much money and time it takes to do that?
It is a very significant lift. When you look at our system, which again is a fee-for-service system, we're serving multiple commercial paid insurance. We're serving Medi-Cal, we're serving Medicare, and then of course you take that across multiple counties. It is a complex system, and we have a huge overhead in just trying to navigate the billing part of that, the regulation part of that, all the paperwork parts of that. I don't have an exact number. We have asked this question a number of times. Our best estimate is that probably somewhere in the range of 30 to 50% of our resources are in that area, whether it's the billing side of it or the regulation side of it. And again, when you look at the scarcity of behavioral health resources that are available currently, that is a huge concern.
Yeah, I mean, that's very disturbing. And it occurred to me as I read through some of the written material and I was listening to your testimony that I would suggest to staff that one of the graphics that we could produce as part of our report would be just a very simple, if that's possible, a graphic of a patient, a child, and then all of the different sorts of entities and organizations that have to be managed by a group like yours in order to get services to that kid. And I'm guessing that you're going to have a long list with lines that overlap, because I think one of the ways to get people to pay attention to how dire this is to give them a cartoon. I mean, maybe it's just me, but I can absorb information better with graphics. And I just think people have absolutely no idea how much you have to do in order to get a dollar into the treatment stream to take care of somebody. So you may continue. I might.
Yeah, the other point that I would make is COVID changed a lot of things for behavioral health. One of the things that's a major change, but I think in a good way, we learned a lot of things that may be useful going forward, and that is the pivot to telehealth. Prior to the pandemic, about 10% of behavioral health was delivered in a telehealth format, and about 90% was delivered in person. In about a month's time, this industry has pivoted to flip that upside down. And I know locally here, we've changed that to be about 80% of our services currently today are delivered in a telehealth format, and 20% are delivered in person. And that 20% is primarily the inpatient side. Anything beyond inpatient is now being delivered in a telehealth format. That was a huge change for an industry to go from where we were, which was we had very big concerns about telehealth and how you could do that, if you could do that, ethical issues of doing it, HIPAA concerns, having to make all of those investments to be able to provide good quality behavioral health care in that way through technology was tough. But we learned a few things. We learned that when we did that, we increased access. So we have patients that are now able to access behavioral health care that wouldn't have if there wasn't a telehealth option. And we've also increased utilization, which was a shock to a lot of us. In behavioral health in an outpatient standard, like the standard 50-minute once a week kind of deal, we know that the modal number of sessions a patient shows up for is 1, meaning that most patients show up for 1 session and they don't come back. We're seeing that modal number now move. Okay? We don't know exactly what it is, but anecdotally, we're seeing that move. We're seeing that patients are more likely to actually show up for appointments, which is great, because if we can do that, that means that we're making those services and those resources serve more efficiently. We no longer have therapists who are sitting there waiting for an appointment that doesn't show up. That's becoming a rarity. So we're using the resources better. It does mean that we still have some things to work out. So prior to the pandemic, we were not, as an industry, allowed to provide what's called partial hospitalization or intensive outpatient programs via telehealth. Through executive orders that came out, we were, and we have the ability to do that, and we are providing great care, and we've learned how to do that. We're hopeful that those executive orders don't sunset before those regulations become long-term.
Commissioner Buiza, I believe you have a question or comment. You need to, there you go.
Yes, I know. We've been doing this for a long time and we can't quite master it. Thank you for joining us, Dr. Distelberg. I'm just very curious because you run a research institution. Do you or have you undertaken research around race and ethnic disparities during this time period? From my understanding and the work that my own organization does, that there's really been serious disparities in this area, whether it's access to general pediatric health care or behavioral and mental health care in teenagers and young children from communities of color. So I will probably be asking this question with the other speakers as we're down the road, but just wanted to ask you first.
Yes, no, thank you for that question. That's a really important point. I think Dr. Insel in the last testimony mentioned the fact that there's 2 pandemics going on, right? The physical virus side is really the pandemic for the 65 and older, but we have this other pandemic, which is the mental health side, which is really disproportionately hitting any from like 25 and younger. So that is a major issue. Inside of that population range, we know that there are health disparity issues. Yes. There are issues of economic disparities that happen in terms of access and utilization for both mental health and physical health. These are well-known things that have been studied. SAMHSA, HRSA, CDC have great studies on this that show this. And then for us locally, we're very concerned about San Bernardino. It has a lot of resources, but there's a lot of mistrust for the resources as well that comes with some of these populations. And the way to solve that is that we get out of our hospital buildings and we go into the communities. And we do things like some of the great new things that are coming are these ideas of promotoras or community health workers and navigators. And we've launched a number of innovative projects here that we are studying currently because we see great value in those in terms of building trust and building access and utilization. But yes, I would say that is a significant concern is health disparities.
Yeah.
Doctor, also, isn't it true with respect to outreach that there are limitations for reimbursement?
Yes, yeah. I think one of the things that we're very interested in, we're exploring and we're investing in is this idea of navigators and community health workers, as well as collaborative care models. There's a great model from SAMHSA called the Impact model. All of these things are wonderful and the research is solid on these, that they work and they provide better access, better utilization, better outcomes, but there is no reimbursement for them unless you are an FQHC. So for Loma Linda not being an FQHC, we are using our overhead, right, to be able to have these kind of services. There's no reason why you couldn't have a navigator that's attached to CPT codes and getting that service billed. I think that would be a really great step forward that would help a lot with health disparities issues. It would not solve the problem. There's a lot of issues there in that to unpack, but that does allow a healthcare provider from the community to talk with their community and build trust and build bridges between that community and the health resources.
Thank you. If you have additional points, I'm waiting to see if commissioners have more questions, but time is yours.
Great. I think that those are my main points. I'm happy to expound on any of those, but I would say our unique perspective here, I would echo everything that was said in the previous testimony. We're just bringing the perspective of a hospital, which is we're really struggling with kids in the ED. It's a significant problem. There's too many of them, and there's a bottleneck of services after that. I think our solutions to that is we should be looking at increasing the number of inpatient beds for youth. That's something we have to do, but not just that. We should also be looking at other innovative approaches that look at more downstream catchments. We're really interested in behavioral health integration programs. We find that the funding through DHCS, the Behavioral Health Integration Initiative, is a really great step forward, as well as CalAIM, and specifically for CalAIM, I do think it will help by bringing in the MCPs to have some leadership. I think they do a great job. And it will also, hopefully, CalAIM has a solution for the Promotora Navigator issue that we were just discussing. Part of CalAIM will bring in more CPT codes that are more oriented to things that are value-based care instead of fee-for-service-based care models.
Thank you. I have Commissioner Varner, Commissioner Byer, and then Commissioner Aroner. But I'm sorry, Vice Chair Varner.
Good morning, Doctor. Thank you for being here. Can everyone hear me okay?
Yes.
Okay. I serve as a director on the Loma Linda University Children's Hospital Foundation, and I really appreciate all that you all do for the children of our communities out here. My question is more around preventative type of care, and what sort of interaction can be done with the schools, and not only I guess it's called trauma-informed teaching, but the teachers identifying potential issues, but also even before that, is there, and maybe it's a little bit of an idealistic viewpoint, but something that we could do with the children to prevent potential issues, mental health issues within the schools?
Yeah, there's a lot. It's hard to unpack every potential option there. I think more can be done, and there's a lot of great programs that are being piloted, some that are here locally, but I think that one of the solutions is the Promotora community health worker model, because CHWs have the ability to go into schools and work with kids, and they do presentations on mental health and they work with the teachers. I think that's a very innovative way to help that community, particularly the school and the community around that school. I know that one of the things I've been concerned about locally here as a parent of a child in the public school systems is the lack of counselors. And there's been a continual reduction in the number of counselors available to schools. And when you talk to counselors, they give you very, very dire stories about how they just don't have enough time to help the kids that really need help because they're a counselor of whatever ridiculous number they have to serve, 300, 400, 500. That's just not a way to do behavioral health. I think that is a solution. I would just highlight though, I think one of the other parallel solutions to that is behavioral health integration, where we move behavioral health professionals to be working side by side with primary care, particularly in pediatrics. We've been doing that here locally. It works. FQHCs have been doing it since 2008. And it's amazing that you can pick up these things earlier on in an annual visit, or the family is much more likely, if they see something at home, they're much more likely to go reach out to their pediatrician than they are their kid's school teacher. So if you have a parent that's struggling with a kid, they'd be more likely to call their pediatrician than they are to talk to the kid's school teacher, because they're afraid of what the consequences of the school teacher being involved in that. Now that has to be solved. That's a stigma issue and we need to invest in changing that. But we're not doing enough to take one of the lower hanging fruits, which is if you can embed behavioral health in your primary care situations, that becomes part of the annual assessments that are done. That's a really good way to catch things earlier so we don't need kids going to the ED.
Yeah, I have children in the public school system out here as well. I live in Riverside, and I talk to the counselors and I know how overwhelmed they are, and they just don't feel like they have enough time to communicate with all the children they want to communicate with. And there's situations I'm sure where children, the mental health issues could be a product of at home and the parents just don't even see it. And I know my daughter sees some things with some of her fellow students and friends at school, and it's heartbreaking. And so it just seems like there should be something at the schools where people can identify that and be able to do something a little bit more quickly than where we're at now.
Yes, and I would just add one more wrinkle to that is there is an education thing there for the counselors. We should be having more counselors, more mental health services in schools. But at the end of the day, and it's a problem that we have on a lot of our funding streams or a lot of the grants that we go after, which is these grants want us to screen for things. I can screen for things, but my problem is when I screen for it, I find it, but then I don't have anywhere to send these kids, right? And that's where a lot of the counselors in the schools are frustrated is they know that there's a problem, but they don't know what resource to send to the kid to, especially if that child is a low income kid that's relying on Medi-Cal only services.
Thank you. Commissioner Byer.
Doctor, thank you very much for your observation about the federally qualified health centers. I, for a number of years, was the chairman of the board of a FQHC associated with UCSF Benioff. And so I completely agree with your point about integration of mental health and physical health and the benefits from it. My question is one of scale. One of the things that the governor, I believe, is going to announce, and it relates to an earlier Little Hoover study on job training, that is the crying need for training of non-psychiatrists, non-psychologists, community-oriented health workers, including peer level folks. And it seems like a perfect opportunity to use a bolus of money, which may be available only for a couple of years, to create the human infrastructure to do the kinds of things that you're talking about. If you were to get money for that kind of program, how or would you cooperate with local community colleges and medical schools or others to train up the thousands and thousands of people who are going to be necessary to deal with this mental health crisis?
I love this question. Thank you very much for this. This is a growing edge of behavioral health, and I've kind of alluded to it a couple of times, which is this idea of community health workers, which comes out of this study and the practice that was done in some of the Latin American countries around promotoras. We at Loma Linda actually are affiliated with an FQHC. It's called SAC Norton. And that SAC Norton also recently, in collaboration with some of our community partners, launched a community college called the Gateway College. One of the certificate programs that exist in that Gateway College is a promotor or community health worker training. It's an associate degree training. We are finding that that's an amazing product for a couple of reasons. One, it's a great entry-level career path for somebody. We're seeing a lot of our CHWs who go through that certificate training and they do that work, and then they may decide while they're doing that, they want to become an RN. And then they move from an RN to an NP and beyond. Or they go from that community health worker and they take the behavioral health path. And so they go from being a community health worker, an associate's degree, to get an undergraduate degree and a master's degree in some behavioral health field. So there's an economic argument that those positions are really helpful in terms of a labor and industrial argument. From a healthcare argument, I think they're wonderful. I think the data is pretty clear. It's coming out of a lot of different places, particularly SAMHSA. It does get attached a lot to the FQHC models, where if you have community health workers, they will serve the community better by bringing the hospital-based resources to the community, or when that's not possible, creating better bridges. The other thing that they do very well is hospital-based care is very disjointed. It's very siloed, and to go from one specialty to the next is complicated. And these community health workers know those systems better, and they can help their people from their communities navigate those systems better. Directly to your question of what would we do, we are already starting that. We just piloted 6 community health workers currently. We're hoping to bring that 6 up to 9 by September. So we have built in kind of an organizational structure where it's very tricky to figure out where do you house them in an industry or in a big system like Loma Linda. There's careful questions that have to be thought about of where do you put them employment wise, what's the structure over them, because wherever you put them employment wise could create barriers for them, and you don't want them to have barriers. The whole point of them is that they are the free from barrier side of healthcare. So we are launching that right now. Based on other models that we've seen. And the model that we have seen here was a model that was funded by Loma Linda through NIMH about 10 years ago, which is where the Gateway College, our community college partner, that program was based on NIH funding that built that training for community health workers. But we're very excited about that. We see that as a solution for many problems in healthcare, but it's also an industry, a vocational and economic solution as well.
Commissioner Erner?
Yeah, Doctor, thank you so much for your testimony. It's been very interesting. You kind of alluded to a couple of things that I wanted to maybe dig a little deeper in regards to coordination at the state level. To start with, we don't have a Department of Mental Health or a Department of Behavioral Health any longer. We have a division within the Department of Healthcare Services, which is kind of a stepchild, I think, at this point. And doesn't get as much focus as it should. But also, we have a disjointed community system, as you mentioned earlier, right? We have 58 counties plus 2 city mental health departments. I happen to live in one of them. I live in Berkeley. And then we have a whole system of community-based organizations and hospitals and all of that. And I'm just wondering, like in your community where you have your huge Loma Linda facility, right, with all kinds of things going on, but what's going on with the rest of the hospitals in your community? Are they just as engaged, or are you it? You know, that kind of thing, because as you mentioned when you began the conversation, there are very few beds. There are lots of people who would say that's not the worst thing because that's the most expensive kind of care to be delivered is in a hospital setting. And so why don't we do something about, you know, getting to those kids earlier, that kind of thing. But I'm just wondering what your larger community looks like.
Yes, I appreciate the comment on the beds. I think there are a lot of people that would push back and say we don't need more beds because of the history of inpatient facilities as well as the cost. And I agree with that, but I also think that we are so under capacity that no matter what we do with upstream or preventative care stuff, we still probably need more beds to serve even those that will need that level of service, even if those other things happen. So I would make that argument. To your question of other hospitals and other service providers in our area, I think what people don't understand about healthcare that aren't in it is that healthcare is not a competitive industry. It is an industry that is truly mission driven, at least when you talk about the nonprofit facilities, the community facilities, the government facility. It's all about trying to serve the community, and we don't have enough resources, which forces us to partner together and work together. We work very closely with the 6 other children's hospitals across California. I have weekly calls with them as the director of research for behavioral medicine, just connecting and coordinating, tossing ideas back and forth on that level. Locally here, all of the hospitals and the service providers are very well connected. Loma Linda is an affiliate of our FQHC hospital, which is the Sac Norton Hospital. But then there's the Riverside Community Hospital, there's Redlands, there's Riverside University Health System. We work together daily because this challenge of serving this population is too big. We have to work together.
Thank you. I see no other questions or comments. And Dr. Distelberg, let me express our gratitude on behalf of the commission for your time, your wisdom, your experience, and your dedication. Thank you so much. So I understand we've got at least 3 more witnesses. So Tristan.
Thank you, Mr. Chairman. Our next witnesses this morning are Ken Berrick and Robin Detterman from Seneca Family of Agencies. Mr. Berrick is the founder and chief executive officer of Seneca Family of Agencies, a nonprofit agency dedicated to providing unconditional care to children and families through comprehensive education, mental health, juvenile justice, placement, and permanency services. Mr. Berrick is a governor's appointee on the Mental Health Services Oversight and Accountability Commission, as well as on the California Child Welfare Council. He is also a 2-time former president of the California Alliance of Child and Family Services, an elected member and past president of the Alameda County Board of Education, and past president of the California County Boards of Education. Joining Mr. Berrick in the testimony is Ms. Robin Detterman, who is Chief Program Officer of Education Services at Seneca, in which role she provides ongoing supervision and oversight of the implementation of Seneca's unconditional education model. Ms. Detterman is a graduate of Stanford University, where she earned a master's degree in education policy and organizational leadership. She is also the co-author with Mr. Berrick of Unconditional Education, Supporting Schools to Serve All Students, which appeared in 2019 from Oxford University Press. Mr. Berrick, Ms. Detterman, please.
Thank you so much, and thanks for having us. I can't imagine a better opening than Dr. Distelberg, who really laid out, I think, the issues in a remarkable way. And part of what he laid out is what happens at the highest end of the system, the youth that are in acute crisis, and how we work with youth in acute crisis in ways that aren't always optimal. And I particularly appreciate his recognition of the fact that one of the places where we work with those youth is in emergency rooms. In ways that compromise our ability to be successful. Where Seneca comes into that is that Seneca started in 1985, initially at the highest end of the system, youth who had the highest needs, primarily in foster care and juvenile justice, and creating programs to avoid hospitalization. But we very quickly moved from that very narrow focus to a broader focus so that we could begin to see how we might prevent youth from coming into those high need systems. And so now Seneca serves most of the California coastal counties across mental health, juvenile justice, education, and child welfare. And we try to do that in a way that integrates services and that provides for systems to work together to prevent youth from reaching crisis. COVID has presented some really interesting challenges and some amazing opportunities. Many of the things that we thought about doing, that we wanted to do in terms of virtual service, but we're not able to do, have come into play in ways that I think can be game changers coming into the future. And we've also been able to serve thousands of youth in outreach programs related to our school-based services, where we serve over 100 schools, primarily in the Bay Area. So I want to give you an on-the-ground perspective, and I also really appreciated your engagement and questions. Feel free to interrupt her or interrupt us as we go forward, both on system-level questions and on specifics. But with that, I'm going to introduce Robin to give you the on-the-ground perspective of how our services have pivoted towards COVID and what we see as next. Robin?
Hello, thank you for hearing our testimony today. We can skip to the next slide. As Ken mentioned, we oversee and provide a huge continuum of services, beginning with those preventative school culture and climate, whole school wellness programs that Vice Chair Varner, I think, was asking about in the prior testimony, and including more intensive services, one-to-one counseling services, supports for teachers, and intensive environments, both classrooms and separate schools where children with intensive behavioral and emotional health needs can be supported to access educational services. In addition, we'll talk a little bit more today about our school-based wraparound and our mobile response teams that have been a huge aspect in this pandemic, and we think are key factors into the next phase. Next slide, please. I think one of the most important things as we move back into the world of education, welcoming students back onto campuses, is thinking about what we can learn from the past year. It has been a tremendous year with just a huge amount of loss and difficulty that I don't think needs repeating in this group. But as we come out of that phase and move on to the next one, there are really three features that we want to help inform the next realm. One is that we've really broken down the barriers between schools and classrooms and families and communities. School becomes home, home becomes school. And we've always, as educators, understood the value of family engagement and have had to really think differently about what it means to provide a behavioral and mental health service that usually happens in the classroom in the context of a family setting. For example, if it's usually a behavioral support that is about attending to school, what does that mean when you're over Zoom and the conflict is between the child and their sibling, or at the dinner table, or figuring out how to even make the Zoom room work and engage in the academic content. And so that has just meant we've been able to engage in families in new ways. And those ways have been profound and transformative for students who have struggled, and really illustrate the ways in which we cannot continue to separate services that support the home environment and services that support the school environment, and that those must have increased and further integration. I think the other piece that we've learned a lot about, it's become really central to the national agenda and understanding of what teachers have been through this past year, but always crucial has been an element of teacher wellness and the ways in which teachers' experience in the classroom can be fragmented and unsupported. And so how we, particularly for students who have intensive mental health and behavioral needs, can build the skills of teachers, both as our prevention and early intervention measure, and also take care of them so that they can themselves maintain a level of self-regulation, a level of wellness, and ability to care for students with most intensive needs. And the third is we've learned a lot about what it takes to educate students. I think coming from the world of special education, we've always believed in a model of individualization. And while many students have struggled during this time, there's a small group of students who have actually done better. Students with intensive mental health needs, school phobia, senses of increased isolation, have not had to navigate the difficulties of the school environment, and therefore actually been able to thrive in new ways. And I think it's important not to forget that this flexibility that this setting has allowed for and really creates new opportunities as we move into what's next. Next slide, please. We've long looked at a model in education in our schools where many of our existing systems require students to fail before they can get help. In our mental health system, students have to receive a diagnosis. In our special education systems, students have to reach a certain point of regression before being qualified with a IEP. And our thought and the interventions that we'll put forward next are really to think through how we connect students earlier in their trajectories, such that they don't get to the point of failure. That one is a trauma in and of itself, is an experience of failure for them and their families, and also can lead to pathways of institutionalization, either through mental health systems or the juvenile justice system. And thinking about solutions as we, as a country, grapple with the racial inequities within our institutions, and including education, how we limit the response of law enforcement and other institutional measures into the lives of our students, and instead build preventative and holistic and community-centered approaches to care. So we're going to talk about a couple of our models that have been successful and we think have promise in the next phase of the return from the pandemic. And we'll go to the next slide, please. The first is really thinking about our schools as communities of wellness, first and foremost, before they can be communities of learning, and places of healing as we return from our separate time, and places where children experience a sense of belonging, are connected to others, have deep and meaningful connections with their educators who understand where they come from, what their community and personal experiences are. And that comes through a series of culture and climate interventions where every teacher in the school has the same approach and is trained in a way that, in a systematic way that can be implemented across the school. I think further, our culture and climate work is really related to coordination of services, which has been essential in this past year. We made a dramatic shift a little over a year ago from coordination of school-based services to simply reaching out to families and really understanding what their needs are and what is the pressing need in the moment, whether that's food delivery or housing access, and bringing those two pieces together as we return. We've begun to work with a number of schools and LEAs around recovery programs using their recovery funds to both find and re-engage students who have been separated from school during the pandemic, and also to engage in that coordination effort to address new needs that have arisen as a result of this time. The second is a model called wraparound. It's typically a model used only in high-end referrals from child and family services after the point at which child and family services has been involved and a child has potentially or is at risk of being removed from their home. We have begun to think with counties with whom we collaborate on how we can deploy that service much earlier for children. The case I always think of as a family we worked with in Richmond of 5 children under the age of 12 who lived with their father, and he was shot and killed. And it was an incredibly tragic situation. 2 young uncles, both in their early 20s, stepped up to care for the children. Because they were in kinship care, they wouldn't necessarily qualify for a wraparound service. And these 2 young men were incredible, but ill prepared to take on the needs of the 12 children or the 5 children in the family. And because of the leadership of Contra Costa County, we were able to engage them in a service that looked a lot like wraparound. But we need to think about the ways that we can, which means that they were able to support their all the basic needs of connecting them to various services and coordinating the mental health treatment for the family. That's rare and not the case in many systems. And if a family or a child or a school person could make a call to get this kind of support for a family when they saw the early signs of struggle within the family, it would likely lead to fewer cases where the family stress escalated to the point where a report to a child's family services was needed. And I'll pass it back to Ken, who's going to talk about mobile response and some ideas we have for future policy.
Great. There are a couple of things that have happened coincident to COVID that are game changers, and one of them was announced yesterday. I just don't think that we can underestimate the potential impact of the governor's focus on social emotional learning, because it enables us to think of whole child, to think of cultural context, to engage communities in a way that we've never been able to do that before. And I want to think about that starting from the lowest levels of need and preventative kinds of efforts that we can engage in, all the way up to where Dr. Distelberg started us, which is how do you avoid that crisis? How do you keep young people from getting into the hospital? So,
Mr. Berrick,
yes.
I'm going to take you up on your offer about
Terrific.
commissioners asking questions.
Can
Commissioner
we lose the PowerPoint there so that we can see each other?
Commissioner
Great,
Bach
thanks.
has a question. Thank you, Ken.
Yes, as a longtime participant at multiple levels and from multiple sectoral points of view, both your work in Alameda and at the state level with the Oversight Commission, we've been looking at mental health for a long time. And I think everyone is very reluctant to say anything negative because we were in such a ditch before the proposition passed under Darrell Steinberg's leadership to add more money. And so that was the dilemma we faced in our first report, in our renewed second report, and we're facing it again now. So as a person who's lived through all those changes and reforms, what mistakes has the state made in trying to, quote, reform, unquote, its mental health system that we should not make this time around?
A great question. Well, the first mistake, and this is not a popular answer with everybody, but the first mistake is to pass the proposition and pretend that we had solved the problem. The vast majority of funding in our system has to come through our health systems, be integrated in our schools. And believe me, I'm a huge fan of the Mental Health Services Act and what we can do for the flexibility it brings with state support and to be able to do innovation, to be able to do different kinds of integrated services. That being said, it's not possible for the Mental Health Services Act to relieve homeless mental illness, to be a game changer in deinstitutionalizing people with enormous needs, and to transform schools. And I think that's why some of these new initiatives that can take MHSA and use some of the creative approaches that we've integrated there, but that can go farther to say mental health is a part of who we need to be as a community, and it can be integrated in every sense. And so when Robin talks about unconditional education, part of that is to say it is not a traditional approach. It's to say, when you put a school climate culture effort into a school that everyone understands, that primary intervention is going to save you from students moving to the next level of needing greater intervention. And when you do that, that greater intervention can be more effective and more targeted. And when you do that, it's going to save a number of students from going into crisis. And that's going to reduce your need for mobile response, reduce your need for crisis services units, reduce your need for hospitalization. Part of the reason that we have kids in emergency rooms, and believe me, I don't think anyone would disagree, an emergency room is not the right place to take a young person for a mental health crisis, is because we miss so many steps along the way. So I don't want to dismiss the point that Mental Health Services Act has been absolutely crucial, but it hasn't been enough to fix the lack of integration. In this case, I'll speak specifically to schools and to crisis services.
Good, thank you. You may continue.
Okay, great. So let's look at the potential game changers and start with this idea. And I began that, I think, in my response. Actually, if I may, I'm going to go back for 1 second. I do think, and I've been talking with Toby about this, that we need to be able to report out to the public what the Mental Health Services Act does and how it's been a game changer in and of itself in the areas that it's focused on. And as we move into school climate, school culture, integrated school services, we need to do the same there. We need to take the governor's initiative and say, what is it going to do and how is it going to do it? So let's start with the idea of a young person that is in crisis. And I'll use the example, San Francisco did something really unique. We passed another game-changing piece of legislation called FERS, Family Urgent Response System, but only for foster youth. And when COVID hit, the mayor of San Francisco asked us if we would expand that urgent response system, that mobile response system, to all young people in schools. That will be a game changer. Instead of a student who's in crisis when they come back to school being met with a police officer or being met with an ambulance and being taken to a hospital, we'll be able to deploy a mobile response team to be able to support that young person. That kind of change is one that will help us respond not just to the COVID crisis, but to the other crisis that that was referred to by Brian of the dramatic increase in youth suicide. We have right now, if a teacher sees a young person in crisis in most schools, they have two choices. They can call a social worker to refer to child welfare if they think there's a family problem, or they can call the police. Neither of those are the right response for a young person in crisis, in mental health crisis. In addition to that, when you take tiered responses, starting with school climate, culture, integrated preventative measures, and tiered up to the kinds of targeted interventions of group work, family work, and individual intervention, what you can do is take pressure off the higher end resources in your system and support young people where they are and where they need to be. So we have some opportunities that have been created both by what we've learned with COVID, how we've learned to use remote services, how we've learned to do outreach to families in a different way and engage families, and how we can potentially avoid deeper end systems involvement by targeted intervention at earlier levels and by using these efforts, school climate, culture, and integrated services to our best advantage. So I'll stop there and see if there are other questions.
You know, I'm trying to read my commissioners' faces, and I know that it looks to me like Commissioner Buiza has something that, no, she doesn't, because the earlier question that the commissioner asked was a recognition of the disparity. And it seems to me in reading through your material that that is one area that I saw more of an emphasis than perhaps in other providers. Am I correct?
Are you talking about racial and ethnic disparity in the implementation of Mental Health Services Act?
Did I guess right, Commissioner Buiza?
Not just in the implementation of MHSA, but in general, because what I asked the earlier witness is that what we've learned is that many children of color have suffered disproportionately from the impacts of the pandemic, whether it's access to digital technology or if they're products of homes where domestic violence is prevalent, for example. That was actually the question that I was actually going to ask you around your wraparound services, right? Like, what is given the statistics that we've learned now around the almost 100% spike in cases of domestic violence, what does your wraparound services mean around that? But also really also curious, what are some of the things that you've learned in the past year around barriers for children of color, especially Latino and African American children, in accessing some of these services, whether it's something that's covered by the act or just services that you provide yourselves, that have you been doing for a long time?
Yeah, thanks. Well, I'm going to answer that in a slightly roundabout way. You know, one of the projects that we started actually at the beginning of the pandemic was a national project to connect young people who had been separated from their families at the border. You all know through the testimony here and your own experience that trauma is cumulative. And these young people had the initial traumas that brought them to this country, and then they had the trauma of being taken from their parents. And we were able to assemble an entirely bilingual, bicultural, deeply experienced clinical team to engage the families. And first we had to engage the families. Because knocking on someone's door and saying, by the way, do you need mental health services, is not going to ever work. You have to be able to engage. You have to be able to bring folks into trust, and then to say, let us find additional ways to help you. It's also silly to tell a family that's homeless and hungry that we'd like to offer them mental health services, right? So you have to take a holistic approach from the beginning of that. That team developed during COVID and happening mostly remotely, almost entirely remotely, I think really has informed our practice going forward as we transition youth back in, which is that just saying services have to be culturally appropriate is an understatement of huge proportion. They have to be community integrated. They have to be knowledgeable of families' experience. And they have to be, in this case, as it relates to schools, integrated into the school community too. So youth community, home community, and then culturally integrated. You have to be a part of the family, the family of the school, the family of the community. That's when you can really penetrate into families. That's when you can really have an impact. And so I think going forward, certainly we saw the barriers far more dramatically with families, certainly in poverty, but far differentially impacting families of color in ways that was really dramatic. And so your starting point is access to both the technology and the people who can engage, and sometimes going out and knocking on doors. You know, sometimes technology just fails. And so we've done a good bit of that as well. So we expect to see that going forward, and we expect to see teams that are really teamed with school, community, family to have an impact.
And just to add,
Sure, go ahead.
Sorry, I was just gonna flag something for you because we do work with these populations and unaccompanied children that you were referring to. The issue of telehealth and access to wireless technology has been very, very prevalent in these communities, because as you know, some of them live in garages and they have to go to libraries to have Wi-Fi, but libraries are closed. So I just want to emphasize that the pivot to telehealth does not work for everybody. And if it's something that is in your radar, I would really love to flag that.
Thank you. Robin, did you have something to?
yeah, I think the piece that I was going to add is I think we're all clear that the disparities in education were simply highlighted by this pandemic. They weren't necessarily created by it. And a big piece of that, and thinking about recentering communities, particularly communities of color, in the world of their own educations, is thinking about how we access, or how individuals and families can access services in ways that are different from the current models, and how schools can be hubs of access so that people that are within communities and really know communities and families deeply can be the ones to make decisions about their care with families in that integration. Because I think when we think about the potential increase of violence in homes, that may be true in some cases, and there are certainly a subset of students who did not get a referral that they maybe needed, or someone to notice that what was happening in their homes. I also suspect there is a group of students and families who may have been in a school where frequent calls to law enforcement or child and family services were not made because they were not engaged in a system that often made those calls as a result of not understanding the individuals and the family's cultural context, and the kind of racial bias of educators in schools. And so I think with that, in the culture and climate, in the whole school interventions, has to be an intentional focus on building understanding of implicit bias, understanding of the ways in which our own cultural experiences inform the ways we interact with families, and how those are all inherent in the work that we do. And so I think that teacher training piece, the teacher capacity building piece, both around mental health and creating welcoming, caring communities where families feel a sense of belonging are a big piece of that as well.
Just, Robin, sorry if I
Thank you.
missed this in your
Yeah,
presentation.
let me mention Commissioner Buisa and then Commissioner Emerson. And then I think it would be important to get to our next witnesses, but go ahead. Commissioner
Just
Buisa.
very quickly, how language accessible are your programs?
They match the language capacities of the communities and schools that we serve. So the majority of that is Spanish, but also a small amount of Arabic speaking and Vietnamese speaking in the families that we serve.
Thank you. Commissioner Emerson.
Thank you. I'm interested in the San Francisco Unified School District Crisis Mobile Response Team. How many are on a team and what qualifications do those individuals have?
Thanks for the question. We'll typically take a bachelor's level or peer counselor and match them with a master's level clinician, and they'll typically respond together. And the same team that responds in the school can also respond at home and provide family support and integration. And I think as we talk about communities being reluctant to access mental health services, part of the reason is that there's always a fear that that's going to take them down a road that's going to make them system involved rather than engaged in supportive services. And so mobile response has really been a key intervention opportunity. We also can pair mobile response to services like wraparound so that it's not just a short-term service, but we can provide longer-term intervention and really help stabilize a family.
Oh, thank you very much.
I want to thank both of you for your written testimony, your recommendations, and for the information that you gave us here today. I think you can tell from the response by the commissioners that they found it really enlightening and very, very helpful. Thank you both for the work that you were doing.
Thanks for having us.
Thank you. Have a good day.
Thank you. Tristan, you're up.
Thank you, Mr. Chairman. Our next witness for the hearing is Our next witness is Pia Escudero, Executive Director for the Division of Student Health and Human Services at Los Angeles Unified School District. Ms. Escudero is a mental health leader and social work professional with over 30 years of experience in mental health and health programs for the Los Angeles Unified School District. As Executive Director of the Student Health and Human Services Division, Ms. Escudero directs over 2,000 school mental health and health professionals, including social workers, nurses, pediatricians, child psychiatrists, human relations and restorative practices experts. Her expertise includes the development, implementation, and evaluation of high-quality interventions that promote resiliency, healing, and lifelong health. Ms. Escudero, thank you so much for joining us. Please.
Thank you for the opportunity to testify and be part of a listening session of our wonderful partners who are doing amazing work in the field. I really feel that this is a critical time for schools and your advocacy on our behalf, as we seem to be having an opportunity coming out of COVID and looking at coming back to school with a small window of opportunity to reset what we've been doing and how schools have been funded to provide these holistic services to enhance and ensure that our children are successful in the classroom. I must tell you that I begin with a concept that California education system has been very poorly funded at the local, state, and federal level. So we are in a new era, and it's almost a renaissance era of having funding and looking at the opportunity to improve our services. So with that, I've prepared a few slides and the really high level of our services overview. But I must tell you that I have a lot to tell you about the specific program, especially we have our own mental health evaluation team and other things, but I really, in the interest of time, wanted to give you a large overview of our services. I am honored to lead the Student Health and Human Services Division. I believe today we're inching closer to 3,000 staff, since we've been infused with additional dollars, and we are looking to hire about 1,500 additional mental health nurses and other staff as we reopen in the fall. Our mission is really inclusive to supporting students, families, and now we've added staff to cultivate safe, healthy, welcoming, and affirming learning working environments so that all students can thrive, graduate, and be empowered in our society. Can I have the next slide? So these are the different departments under the division under my opportunity to lead this largest. I just talked to a colleague from Israel. We are the largest cadre of student health and human services, probably in the world, but definitely locally here in California. I oversee district nursing services. We have a small cadre of human relations, diversity, and equity staff, attendance and counsel services. We also have a positive behavior and restorative justice practices team. We have a tremendous school mental health program that I'll be addressing today, and student medical services that really do immunizations and medical services for our students. We also do Medi-Cal reimbursement programs under student medical services. Our student support programs address special vulnerable population, and that's foster, homeless, juvenile justice, expulsion students, and so forth. Our wellness program really lifts the federal wellness policy for schools, the blueprint, and really tries to coordinate all these services into one at the school site and district-wide. Next slide, please. As you know, LA Unified is huge. I usually have a map that overlays how many states fit into our area that we cover. We're the second largest school district in the United States. Our square miles incorporates 26 cities and municipalities. We have 650,000 enrolled students, including dependent and charters and adult schools and early ed programs, 1,400 schools and centers, and we have over 100 languages spoken. I have been a social worker in our school district for nearly 30 years, and I have to tell you, we started with 70 languages. A couple of years ago, we're at 90, and now we're up to 100 languages in our school district. Next, please. The interesting story about LA Unified, despite the fact that we are in the city of glamour, is that our students in LA Unified bring to the classroom innumerable adversities that must be addressed. 60% of our student population is eligible for Medi-Cal. 80, and I would say at some schools 90 and higher percentage of students qualify for free and reduced lunch. Our families that are experiencing homelessness is 19,000 pre-COVID, and that is by them completing a voluntary survey. So there's a lot of stigma, especially in middle and high schools. Our students don't want to be identified as homeless, and so sometimes they're doubled up, and sometimes they're with other family members and other households. We really don't think that's a true number, and now, especially given the conditions during COVID, we know that that's an extraordinary number. In fact, New York City, that has an effort to identify students, they're the largest school district, and their numbers of they call it temporary house families, are in the near 100,000. We have a growing number of students that are in foster care. 1 in 4 did not meet the fitness test requirements before the pandemic. So we know that number has increased after our children have led a sedentary life. And we have serious medical and public health issues to address with increasing numbers of diabetic students in our schools. And I just captured the amount of mental health visits that we have in our district operated clinics. I'll tell you a little bit more about that. We have many families that come to our clinics, and now we're doing that virtual service. So really this concept of why the school site is because here comes a teacher that's trained to do the instructional program. We may have technology, but then you come into the classroom and our children are just not able to feel that safety and that ability to learn because of all the issues they come into our schools. Next. I'm going to share with you some of the abilities of what we've been able to do to meet this growing opportunity that our school district has had, is to expand and look at the recovery of our students as we move into next fall. So we're looking at recovery in a multi-pronged process. It's really not just about mental health, because we've learned those students that have high exposure to trauma are also the children that may be facing at-risk foster and homeless, and they also are the children that are having a difficult time with immunization. So I really like this concept of wraparound services because our families can't be offered one piece of the pie, but really holistic services. So our teams really look at the mental health component, along with increasing enrollment, engagement, attendance, and child welfare issues. We count on community partnerships, even though we have a very solid group of staff. We need those partnerships and bringing lots of community partners at each school site, which requires coordination. And then we also refer, link, and case management. We know we can't do this alone. And really, this school climate concept really became vivid during this pandemic. We were able to, everybody had advisory classes or homeroom classes, really do check in and check out, because one of the biggest problems we faced at the very beginning was this whole Zoom bombing issue, right? What do we do with these kids that Zoom our class and disrupt? The teacher had to turn off the Zoom class and then everybody wouldn't connect back. So we really started saying, what does school climate look like virtually? So we have activities where people check in and check out. We're doing it in our actually adult meetings, and I have backgrounds. I didn't bring them today, but we have Tuesdays, Gratitude Tuesday, Wednesdays, Wellness Wednesdays, and we have some schools that have changed Wellness Wednesday to Woke Wednesday with student voice. So really trying to, despite the fact that we may be virtual, creating that sense of community in the classroom, and really what we're getting at, preventing the pathology, right? I think pre-COVID, our systems have been set up to address a reactive model. So that suicidal student that needs special ed. So the shift and the reset that we're hoping to really work and strive towards is exactly building schools that are healing, as mentioned earlier. And just recently, when we started hybrid attendance, I really saw that principals and teachers all really gearing up for our students that are coming back. And so I think this fall, we're really going to hone in on that school climate concept to capture students that may be at risk before they have a pathology or need higher levels of care. Next slide, please. So what is happening in LA Unified with this infusion of new dollars is the table on the left, the column on the left states what we have at a school site. So just recently, our superintendent and board really has this innovative concept of placing a psychiatric social worker at every school site. That's going to be, of course, a career pathway challenge. We really are going to be working with universities to find staff that have a master's in social work and a pupil personnel credential. But we believe that person being internal, part of that school site, is critical because they work side by side with administration, staff, teachers, and they really become part of that community. In addition, schools that have high population, we will put a student and family resource navigator that enrolls that family in Medi-Cal, housing issues, and all that case management that really allows a psychiatric social worker to do the clinical work. Schools are also being infused with additional dollars. So they're going to be able to purchase additional counselors, restorative practice teachers, and psychiatric social workers. We have schools that have traditional purchase these staff, and yet we still need partners, right? We still need to organize that community so that schools continue to be the nexus to communities. We've learned that through COVID. We've been feeding staff, communities, we've been providing services virtually, and we know that families, they come to school and tell us their sorrows. We know when someone has passed away or when they're losing their home, they're really, for us, because they know the staff is there, we hear that the issues that they're facing.
Ms.
Yes.
Yes, if you may recall, I had advised witnesses that there will be times when you provoke questions. That's a good thing. And I think Commissioner Buiza has something for you.
Perfect, thank you.
Of course.
Thank you, Chairman Nava. You have a very tough job and a very big portfolio, so must be very challenging at this time. My question is, and it would be great if Dr. Distelberg heard your testimony around the number of mental health professionals that are going to be coming to help the district, because that's one of the issues that he raised earlier, is the chronic shortage of counselors. But my real question is, what is the amount of preparation and training that has been or will be given to this cadre of mental health professionals that will be joining the district. Because a few months ago when we had a meeting with Mark Gali, he said that there are thousands of job openings of this type of professions in California, but the shortage of trained ones has been the reason why it has been so slow to hire these professionals. So I'm curious what that looks like for LA Unified, given the demographic makeup of the district, and what you pointed out is the amount of children that are that belong basically under the poverty level.
That's a very powerful and important question. So I must admit, and I'm very proud to say, that LA Unified is a very unique district in the world, and not just nationally, because we're very few districts that can have their own mental health staff, right? This psychiatric social work title does not exist in many districts. And the array of services internally, and that really is attributed to leadership, right? Superintendent after superintendent, board members after, we really know our population, they visit schools, so they know that this is critical work. I myself got hired in the district in 1988 as an intern, and I became a psychiatric social worker. But what happened in the late 1990s, 1999 or so, is School Mental Health, which is our mental health unit, joined in partnership with UCLA and RAND, and we started screening for trauma. I was actually one of the pioneers who developed CBITS, which is a cognitive behavior intervention in schools. So we had researchers come in saying, what is it that you're doing and how do you know it works? So we've been dealing with this concept for all throughout evaluating our program. So trauma became a prevalent issue. And in fact, I was influential with Marlene Wong putting trauma as a Mental Health Services Act item, and especially for vulnerable populations, when people didn't, even our staff would say, oh no, we don't have trauma. Now, 20 years later, trauma is prevalent, but that was a new concept. So one of the things, to answer your questions, is we have trained the nurses, the navigators, the social workers in the science of the brain, the neurobiology, in protective factors, and really shifting that, that behavior that may look like there's reasons why children behave to that versus, really what happened to that child. So we're all trauma informed, trauma and resilience informed, because we don't want to be defined by our trauma. We want to be defined by our resilience. In addition, lots of interventions, which is very unique. So one of the things that happened about 5-6 years ago is we, with our partnership with UCLA, the Nathanson Center, and Semel Institute, we adapted a military curriculum focus, families overcoming under stress, for the classroom. So it's not the usual intervention where, here, teacher, there's a social emotional learning in addition to what you're teaching, math and language arts. The social worker, our staff, will do a classroom curriculum, teaching problem solving, teaching about trauma, teaching about the brain, communication skills, regulation. So the teacher learns these skills as well. So we really have trained our staff. We have also a very large internship program of graduate students. Nearly 250 interns are on the ground learning. So by the time they get their master's in social work, they have that experience to get a pupil personnel credential. But it's really been working with universities so that they have a curriculum that aligns with the practice. So it's a very unique situation that we have in LA, and really it deepens by relationships with the universities, with interventions, and constantly looking at our toolkit to adapt and mold. For example, during COVID, we developed a resource guide with a division of instruction, special ed, everybody contributing. How do you support that classroom school climate? So it's just not mental health telling teachers what to do, but it's with teachers, with special ed, with newcomer experts, so that we really infuse the content universally.
Yeah, I mean, what you're doing, I think, is extraordinary. Most people, when they think about a school district and have no idea about the size and scope of Los Angeles, you just know it's big. You don't know how big. And most people just think that what goes on at a school is a teacher shows up and they spend some time with the kids and give them homework and then they go home. But I think what you are helping all of us, including the public who looks at this, and our staff as we prepare our report, and commissioners as we consider the recommendations, is just how broad the responsibilities are that the district has assumed, and the specific kinds of passion that you demonstrate for the children's well-being. And we can pretty well predict that because of the stressors that kids undergo during this year, that they were away from school and getting to know their parents far too well, that there will be behavioral problems when they come back. And what you and your folks are doing is helping people to understand, a ruler across the knuckles is not the answer here, that there are better ways. We need to build back better, I suppose, is what it is that we're saying. And that we have some opportunities because of this experience to do so. But I just interrupted you, and let me ask any of the commissioners if they have anything else. There's Commissioner Beyer.
Yeah, thank you very much for your testimony. One of the things that we talked about before was outcomes data. And it strikes me that in most sophisticated private sector enterprises, there's a dashboard or some metrics for measuring success. And it seems as though you all have learned a great deal in the school-based care model. What's been your experience in sharing and cross-fertilizing other school districts, large and small, within the state? Because one of the critiques that we had in an earlier Little Hoover report was the lack of common data sources and the lack of information sharing about either best practices or imaginative interventions. And it seems like you have a lot to share. And how does that work, and could it be done better?
That's a huge topic of conversation for us. I have to tell you that because of my experience, long-standing experience, we used to in our clinics have index cards where we did the intake, reason for referral, and that's where Rand and UCLA said, how do you know this works and what are you seeing, right? We now have data sets that are demographics in the district. We have service tracking. We have, if we use a screening tool, we use another world. So the data sets are talking. I must tell you that I think we're in the infancy stages because of the lack of funding to build these clouds to speak to one another. When we initially did CBITS 20 years ago, it was very hard to demonstrate the efficacy of the program because grades didn't match, and we were doing a lot of this internally by hand, basically, right? Tables talking to tables. We are in a position that we're looking at how do we build out, and because of the pandemic, it was the first opportunity that our entire division had Welligent as an electronic health record system. Because of additional funding, we had groups that were also tracking in different worlds. So this is an area that needs a lot of support and a lot of whole different mindset than mine to ensure that data is tied to demographics and it's tied to clinical records with all the FERPA and HIPAA issues. This is an area that I believe eventually I heard our partners and medical partners that how does the medical profession and practitioners manage care, because we see a lot of managed care students, how do we communicate protecting the privacy of families, right? That needs, I think we're poised with the clouds that we have. We're just in that infancy stage of having a dashboard, right? In fact, we have a contract with the Department of Mental Health and we submit MHSA data. We have outcomes, but we don't get feedback. So we have to create our own system. So it'd be nice to know, what we're doing under MHSA or county, or we have partnerships with the city. How do these large entities talk to one another? We have yet to figure that out.
That was very, very illuminating and helpful. And I think it'll probably go a long way towards helping us to fashion appropriate recommendations. Let me check to see whether I have any other commissioners who have questions or comments. Yeah, Commissioner Sidley, I see you.
I'm just wondering, sort of outside of the box question, how is recruiting when you do have openings? How is recruiting to get people to come to work? And how do you go about finding people to come to work?
Well, I have the interesting situation of recruiting heavily for two fields, right? Nursing, school nurses, a dramatic gap in our ability to meet that demand. 400 vacancies I'll probably have next year. And there's just not enough graduating. There's not enough folks really going into the field. And then the salary for a school nurse doesn't compete for, if you're going to be a nurse, there's ways to be really economically sustainable, privately versus going to a public school. So that is one, the credentialing process for nursing, but that's not what we're talking about. I think for social workers under people services and attendance counselors or psychiatric social workers, it's a very desirable job because we have summers off, they have winter and spring, and then people like the fact that we're working in schools and the salaries are good and competitive in the field. So we're doing those recruiting efforts with universities. One of the things that stops an LCSW from applying to the district or an MSW is pupil personnel credential. Universities are offering that course. So really a strong partnership with staff. But I think what you're getting to, which is really another passionate, and by the way, everyone says, am I the only one passionate? I have a team of passionate providers, leaders, because we see the difference, right? And I can tell you tremendous stories that bring me hope. That help me get up every day. There is a tremendous opportunity to create career pathways beginning in high school. And I wonder how we can influence. I know we're working with our adult schools and our linked learning programs. How does a student graduate with a high school diploma and an LVN credential, or a high school diploma and social service field credential or social service aid, or some of the pathways, because then they can start going to undergrad and grad school. That piece, we don't have enough LVN apprentice programs or mental health programs, so that a child right now, we're competing with the fact that children have to work. So if they know that they're going to high school and are going to improve their ability to get a better job upon graduation, it's a win-win. But many times students really have that disconnect and that urgency to work, and engaging those students with the economic instability for families is very hard. But that's another area that I think there's opportunities that we can explore, working with adult schools where even homeless families, giving moms and dads a pathway within we're hiring. So we're working with Personnel Commission to hire those families. We're going to be a huge opportunity to hire from within the community right now.
Thank you. Thank you.
Wonderful.
Nothing else, Pedro. Thank you.
Of course. Thank you very much. I just want to tell you, I'm looking at my commissioners and their reactions to the things that you're saying, and the nodding of heads and smiling. I think you've made a tremendous impression on the members of this commission, because we can sense how dedicated you are. And you were gracious enough to also make sure that you spread some of that gratitude and enthusiasm to your staff, which I think is an extraordinary example of the kind of leadership that makes a difference. We're lucky to have you here as a witness, and I think Los Angeles is fortunate to have you as part of their staff as well. Thank you for your testimony.
Thank you. If I may add, I've been very also blessed to work with folks in the field to infuse leadership framework that's trauma and resilient informed to our leaders and our staff, because this is very hard work. So really working on that staff wellness when you're a provider, if you hear the stories, they're very sad. And the district has a way of notifying us every day of incidents that are happening. Back in the day, 2 years ago, when there was a death, wow, you wanted to know. We were notified about that. Those notifications are happening daily. If it's not a staff member, it's, there's accidents and there's a lot happening. And so it really is very difficult to come in energized and do this hard work. But you've just also filled me with gratitude, because it's an opportunity to tell the story. We're busy doing the work. So if I may, I think there's one other story that, because of the previous testimony, I would like to share with you. About 3 years ago, the chief of police and I did an unfunded partnership just because we knew we had to do it. We knew teachers and social workers and officers sometimes were working for psychiatric mobile response from the county until midnight. schools had to be open because they were waiting for that PET team or whatever it is that the schools call it, right? It's really the smart DMH mobile team. So we launched a very interesting program and then got disrupted by COVID. We had school sites, our support staff, call the watch commander. We had that year 1,500 calls of suicidal behavior, ideation, and assessment requests to our teams. Our teams with staff with school police and social workers would handle that call and walk the staff through that call. Out of the 1,500, 700 or so got an in-person response. That means a social worker with an officer informally dressed would drive in an informal car to that school to help with the assessment. Out of the 750, about 300 were worthy of a hospitalization, and we worked with hospitals to make sure that they had a bed because they had that psychiatric evaluation that was so needed. The rest, a lot of safety planning. Elementary school safety planning looks different than the middle school safety planning and high school with staff, with parents. And so that safety planning, that case management is a heavy lift, but the success of the program is really allowing a school to learn how to create that safety plan for that student and keep them in the community versus going to a psychiatric evaluation that many times in an emergency room they did not need, or they did not get it. They got to go home without an evaluation. We also learned there's no autism expert to assess a child psychiatrically. So we know that there's gaps and cultural differences. So just sending someone to an emergency room, it can actually do more harm than good. So we know our teams just recently reactivated and they're going to homes and schools so we can create those safety plans and prevent that high cost and really traumatic experience of going into a psychiatric pathway that's not necessary.
Again, all right, you've proven exactly my point, and I see Senator Nielsen has raised his hand. You got to unmute, sir. Unmute. Senator Nielsen, unmute.
Yeah, I think I unmuted. I apologize. We were in session and we had an adjourn of memory. I did an adjourn of memory for Justice Cruz-Reynoso, and that's why I'm late here. But I did get to listen to about half of this last presentation, and I want to tell you how moving it certainly is. Let me ask the presenter here, what does she see as the opportunity for getting more mental health professionals to be able to interface and work with our schools? Now, I'll make note of something. One is the paucity of nurses. And it's caused me in the last several years to revisit the master plan of higher education, whereby we would allow more nursing education at the community college level and degrees for nursing at the community college level. There are other things that are related to that as well. But my point being, what do you see the opportunity for more professionals coming in to the school system? I believe because of the COVID situation, we're going to have a lot of needs in years hence.
Thank you for that wonderful question. I think that's why schools are the nexus to looking forward at career pathways. So starting young, really, I think by high school, we can start by middle school, really creating that interest in school nursing. We have a partnership with Charles Drew Nursing, and they've accelerated their nursing program for 3 years. And so we have a pathway, hopefully graduating LVNs that can go into nursing. There's a huge, each pathway has some areas that I could spend a lot of time with. Nursing has a huge challenge for credentials. Most nurses spend a lot of money in their school nursing education. Then they come to schools and they have 5 years to get a credential. The credential is $18,000. And so they've already had debt from their nursing school. So how do we create, and I think LAUSD is advocating for credentialing programs that are cost-free, led by LEAs or systems that are not, in addition, burdening the professional to make a living, right? Make a living wage, do hard work, and then pay for this professional programs that are really burdensome.
Thank you very much.
And once again, thank you very much for your testimony. As I said, I think you made a great impression on all of us. Tristan, I think we have another witness.
Thank you, Chairman Nava. Our final witness for this hearing is Michelle Cabrera. Ms. Cabrera is Executive Director of the County Behavioral Health Directors Association of California. Prior to joining CBHDA in 2019, Ms. Cabrera served as the Healthcare Director for the California State Council of the Services Employees International Union, and as a Senior Consultant for the Assembly Human Services Committee, where she specialized in child welfare issues and staff legislation, which extended foster care in California to age 21. Ms. Cabrera also serves as a member on the National Quality Forum's Standing Committee on Disparities and on the Board of Directors of the California Pan-Ethnic Health Network. Ms. Cabrera, thank you for joining us, and please proceed with your testimony.
Thank you so much for the opportunity to present before the commission, and we have really enjoyed the prior session as well as this one, and are grateful for the opportunity to speak to the heroic work of our county behavioral health safety net. As Tristan mentioned, CBHDA represents the county behavioral health directors for all 58 counties, from LA County's great partnership with Ms. Escudero's team with LAUSD, all the way up north to Siskiyou, Del Norte, and San Bernardino, Inyo, and beyond. If we can pull up, I just have a few different slides, and I want to say Happy May is Mental Health Month to everybody. I'm just going to start out maybe with a quick recap on some of the issues that were discussed as challenges, systemic challenges in the prior hearings and today. Our county behavioral health directors during the pandemic have seen the numbers of children and youth in crisis shoot up 2 and sometimes 3-fold. We have unfortunately seen children and as young as 8 years old with suicidal ideation in our hospitals. We also are aware that as children come back to school, consistent with historic trends for mental health, we expect these surges in youth crisis to increase. Actually, it's true that despite all of the amazing protective factors that schools provide for children and youth, that we see crisis numbers increase while school is in session. And so we can expect these numbers to dip somewhat during the summer, but then come back. And sorry, that's my own kid coming home from school. So one moment. Bring a little bit of dose of pandemic reality to my presentation. I did leave the door open. Okay, so the other issue with children's mental health and SED needs is that children are not little adults. And so clinically, emotionally, and in terms of treatment, we really need to approach children differently than we do adults in our system of care. As the Children's Trust reported in their testimony last hearing, kids don't spend a lot of time in the doctor's office or in primary care after the ages of 4 or 5. And so identifying a serious emotional disturbance for a child can be a really complicated issue, especially when children are nonverbal or aren't safe at home, or when normal developmental shifts may look a lot like symptoms of a mental disorder. And children and youth are largely reliant on the adults in their life to seek care on their behalf. We also know that primary care clinicians, while they may screen for behavioral health conditions, they don't always have the specialized training or education to accurately identify and diagnose those conditions in children. And all of this together can really delay access to necessary care at a systemic level. While not all kids who experience trauma have a mental illness, we also know that children who have experienced significant levels of trauma should be provided with extra support, as Ms. Francis from Children Now talked about in her testimony, as those experiences can certainly trigger anxiety, depression, as well as PTSD later on in life. And as we heard in this hearing and in the last, We know that policymakers, providers, and advocates desperately want consistency from our public behavioral health safety net, especially in terms of how services are delivered, financed, and then how we report on the efficacy of those programs. And county behavioral health directors very much agree with the idea that we need more state-level transparency and accountability surrounding metrics of success. And it's really important for us to communicate to all of you that so much of the variation that we see in our behavioral health system is actually baked in as a matter of policy, both federal as well as state on down. In fact, we believe that it's state and federal policies in large part that have created this consistency, in the sense that we have a categorically funded system, which includes a ton of grants-based as well as inadequate funding. If we can go to the next slide, please. So take, for example, our experience in the pandemic. The Department of Healthcare Services reported in February to their stakeholder advisory group that Medi-Cal services were down in 2020 across all service lines. This includes general emergency department visits and hospitalizations, 2019 compared to 2020. The only services that were up in 2020 were mental health services, and that growth was largely driven by county behavioral health. And yet, as we were going through the experience of the pandemic last year, resources, whether it was PPE, workforce, extra funding, housing resources, et cetera, were largely focused on the physical health components of the pandemic or public health systems. And, you know, early on, that sort of made sense because we didn't know much about what was going on, but amazing researchers found out in the midst of the pandemic that there's actually a bidirectional association between COVID-19 and mental health. So we're finding that COVID appears to trigger new mental health conditions, as well as individuals with mental health conditions are far more likely to become seriously ill and die as a result of COVID. So they're still trying to unpack what's going on there, but clearly there are direct links between COVID-19 and behavioral health. And yet, because of some of the structural issues that we've been talking about with systems being disjointed, as well as just, you know, a lack of understanding of behavioral health needs, it was really hard to really center and prioritize behavioral health throughout the pandemic. The point that I'm trying to make here also is that addressing behavioral health needs will be imperative if we're to really round the corner on this recovery statewide, and that so many of the challenges that we face are systemic. Take, for example, Dr. Insel's highlight last hearing about how the state of California spends more on mental health than any other state. I would hope so. Our population is far greater than that of many other states, or all of them. But on a per capita basis, what we spend on mental health is only slightly above the national average. And when it comes to Medi-Cal as a whole, if we can go to the next slide, what we spend in our public behavioral health safety net is absolutely nowhere near where we're at in terms of the rest of Medi-Cal. So what you see in this chart here, the number in the middle is the amount that county behavioral health is spending in Medi-Cal. That's aggregate. The smaller bar to the right of that is how much we're spending outside of Medi-Cal. And these are our services that can't be Medi-Cal reimbursed. And then the large, tall blue column is what Medi-Cal is spending both for physical health as well as the mild to moderate benefit. And so you'll see that proportionally, even during the pandemic, healthcare spending went up throughout Medi-Cal, even though our services were the only service line that went up during the pandemic. Our funding was flat or even slightly lower than it had been the year prior. This kind of squeezing us financially is not helping anyone. And counties have done their best to be adaptive throughout the pandemic. They have lost staff to COVID They've been field-based throughout the pandemic. They did not stop delivering in-person services because the clients that they serve so often really need that in-person engagement. But you know, the impacts of the pandemic, I would say, have been devastating for our behavioral health safety net. Next slide, please. And, you know, outside of Medi-Cal reimbursement, I like to think about it as sort of the bookends, right? Because so often when we talk about, like Mr. Briscoe's presentation, our Medi-Cal penetration rates or what we're spending in Medi-Cal, it's really important to acknowledge that those non-Medi-Cal pieces, the bookends, are super important. And to a large degree, we cannot fund those under insurance models. We have federal rules which prohibit us from spending Medicaid dollars on treatment facilities that are larger than 16 beds. We also are not allowed to bill Medi-Cal for crisis services over 24 hours. Wait time for our mobile crisis teams, our state hospital costs, or even board and care, including housing for our homeless clients. We subsidize commercially insured beneficiaries who are underserved, and we serve individuals who lack insurance in California. And then upstream, so much of our prevention, outreach, engagement work, and even some of our community-defined practices, which are much more effective in reaching communities of color in California, are not reimbursable through Medi-Cal. So we think it's really important to note that when we look at Medi-Cal data, we're really getting a slice of the picture, and that some of these restrictions are really challenging to overcome. Next slide, please. So the limitations of Medi-Cal funding are also the reason why, you know, we wanted to make sure that you knew that at the federal level, we're also grants-based. Oftentimes we have SAMHSA grants or MHSA grants, CHAFA grants, and all of that bakes in variation. We would also like to speak to you to another area where we think that significant improvement is necessary, and that's on the issue of disparities. If you look at the data of children and youth served in Medi-Cal across both specialty mental health services delivered by counties and non-specialty services delivered by the managed care plans, and then you stratify those data by race and ethnicity, and these are 2020 data, again, reported by DHCS. We see some alarming trends that really must be addressed moving forward if we're going to eliminate disparities and achieve equity within the Medi-Cal population. And just as a reminder, the Medi-Cal population is overwhelmingly comprised of individuals of color, with Latino Californians making up the largest proportion. And so what we see here is that while Latinos and API Californians are underserved by both systems, you know, the county behavioral health system certainly does do a better job of reaching Californians of color within Medi-Cal, and we have a lot more work to do here moving forward. So we would say that, you know, when we've looked at this, counties have a long history of using funding, again, outside of Medi-Cal to try to engage folks into services and try to build up models which can reach these populations more effectively. And we've seen our rates of service to Latino populations increasing. And we're now at twice the rate of the managed care plans for serving Latino children. But we also need to be cautious in that some of the higher rates of serving Black African American Californians, as well as American Indian Alaska Native, may reflect disproportionality in the systems that serve children and families. So for example, if we see a disproportionately high number of Black children in the child welfare system, for example, and county mental health is responsible for serving their mental health needs, we of course would see those higher rates in our Medi-Cal population. So understanding racial and ethnic disparities is complex, but certainly these issues are things that we need to build into our thinking as we look at serving children on a forward-looking basis. And I would say that these limitations don't mean that the state could not or should not do more to maximize the use of our county behavioral health plans. We're really proud of our partnership in the state with the state in crafting the state's CalAIM initiative. If we can go to the next slide. Over the last 2 years, CBHDA has lobbied the state to enact changes that we believe are fundamental to transforming the way that we engage with our providers, as well as opening up access to county behavioral health services, which are unique throughout the Medi-Cal delivery system. We have a downright Byzantine payment system currently, and it is access is restricted by a really high bar medical necessity standard. So our clinicians need to find a diagnosable condition with a child before we can start to bill Medi-Cal for those services. It doesn't mean that those services don't happen, but it means that we often leave federal dollars on the table unnecessarily. We identified this as something that we really wanted to be aggressive about shifting with the state. And so the state's CalAIM proposal does include some of those revisions to medical necessity. It also includes automatic eligibility for specialty mental health services for all child welfare involved children, which we think is a game changer as well. And on the payment reform side, again, it's those state rules and the varied audit risk that we face from county to county. So even how the state enforces its rules is not always the same from one region to the next. That really has led to some of the variation in the documentation requirements and paperwork that you heard from the hospitals and some of the other providers earlier. We have front-loaded trying to fix some of those issues through CalAIM, and while it's all very sort of technical and back end, we hope that the result of this is that we shift away from an audits and compliance-driven system to one that is much more focused on opening up the doors for access to all children who need these services. And we're hoping that relieving some of that documentation burden will also help us with workforce recruitment and retention, because no one goes in to work for the public behavioral health system to become wealthy, but people are certainly feeling dragged down by some of these onerous requirements. I'll also note that the state of California, it will be the 49th state to opt into Medi-Cal reimbursable peer support services. We talked a bit about peers earlier, although I do need to emphasize that peers are not the same thing as community health workers and promotoras. Early in my career, I had the honor of working for a promotora-led organization, Líderes Campesinas. And so I know the promotora model very well. Peers are actually delivering a clinical service from the perspective of a lived experience with a serious mental illness or a substance use disorder condition. And so they really are much more on par with a licensed clinician. And the key distinction here, while some counties have peers currently, we're not able to reimburse for those peer services under Medi-Cal, and we don't have sort of a statewide certification standard. And the challenge with our peer benefit in Medi-Cal is that the state made this an optional benefit. And so again, we've been talking a lot about variation. Counties have to self-finance whether or not they want to offer this benefit. And there won't be any new state funding to support it. And so I just want to be clear again that these are state policy decisions that we're making to not have a statewide peer benefit that gets supported under Medi-Cal. Many counties will opt into the peers benefit because, again, they see the outcomes that peers produce. It is a workforce that we very much want to build up in California and realize, but we're often sort of having to work within what we have already, and that's a challenge for our system. Overall, however, our hope is that with CalAIM, we will move more of those services that we provide outside of Medi-Cal to the degree we can in under Medi-Cal, and that will really won't be leaving as much federal matching funds on the table. If we can go to our next slide, I'll talk a little bit more now about school-based services, which counties are providing throughout California. And we decided, because there really isn't a lot of good existing data about school and county behavioral health partnerships, we surveyed our members in January of this year. And one of the things that we learned is that 85% of California counties are currently offering school-based behavioral health services. About a third of those counties are providing those services in 80 to 100% of their school campuses. And in the chart you see here, we kind of put this together because we think it's important to distinguish between the amazing work that schools do in providing ERMs, or educationally related mental health services, and also to distinguish that from what county behavioral health provides to students at schools, because there's so much focus in this area, especially after the governor's announcements from yesterday. So with ERMs, I think what's important to note is that the scope of practice and responsibility is really education focused. It is, how can we support student learning and remove any mental health related barriers to that learning, to them showing up ready to learn, as we heard in previous testimony. And this is done through a distinct workforce of school-based social workers, counselors, psychologists, and nurses, and in alignment with the federal IDEA, as well as IEP rules, et cetera. County behavioral health has a very different set of responsibilities. Under Medi-Cal, county behavioral health plans are responsible for the EPSDT entitlement, which means meeting all medically necessary mental health and SUD needs for children who are otherwise eligible for Medi-Cal. And then, to the degree that we have extra funding available under the Mental Health Services Act, for example, certain communities have made a decision to invest in this upstream care for all children. And we provide a much broader set of services with a different set of clinicians. So we use clinical psychologists, LMFTs, psychiatrists, nurse practitioners, LCSWs, et cetera. The point here is that you may have a student who is doing okay in school or is not disruptive from a behavioral standpoint, who really may not come to the attention of the school-based mental health staff. And as we heard, the school counselors, et cetera, are really under-resourced. But for that student who maybe flies under the radar because, again, behaviorally, they're not sort of in the teacher's on the teacher's radar, or because they may even be performing really well, but they're struggling with a behavioral health need. That's where county behavioral health brings a different kind of expertise to identify those conditions and is able to tap into a different level of service from the earliest to the most severe. And so we think that these partnerships are really important, that the teaming here complements one another, and really that there is obviously enough to go around in terms of demand and need for services, but that you really can't have one without the other, because you do need that more comprehensive approach. In terms of, I could get into more specifics about the models and how they're financed, et cetera. But again, I think that it's important to remember, and if we can go to the next slide, we can talk a little bit about what some of the barriers are that our folks talked about in terms of building out these school partnerships. One is physical space. So oftentimes schools are using every single building they have on their campus to provide services, and they don't have extra space for providing a dedicated private space for behavioral health services. The other one is sometimes schools are reluctant, and I think this is completely understandable, to pull from students' instructional time to address their behavioral health needs. Although I would say our collective thinking on that is shifting very quickly, understanding the connection between students' behavioral health needs and their ability to learn. And then there is systemically been an underfunding of or inadequate access for commercially insured students. When our county behavioral health departments approach their education partners, they often say, you can't just do the Medi-Cal students, but we certainly don't have enough resources outside of our Medi-Cal reimbursed services to finance everyone getting in. And so CBHDA has actually run legislation the last couple of years to try to make it easier for us to claim and get reimbursed for those commercially insured students. And unfortunately, our bill from this year is a 2-year bill, so hopefully we'll get that across the finish line next year. And so, you know, we think that this is a really invaluable partnership. We think that if we want to look at how to very quickly address the needs of children and youth on campuses, there really is a distinction between what the managed care plans do, which is limited to the mild to moderate mental health benefit, what the schools do, which is supporting education and learning through mental health services, and what the behavioral health plan does, which is a much broader array of services, with a much broader team, and which includes substance use disorder services. And it's worth noting that children and youth, for them, the rates of co-occurring substance use disorders and mental health conditions are actually higher than for adults. So, you know, we think that this is an important aspect of identifying which kids might have behavioral health needs on school. I'll say one more thing because I think it's relevant to some of the earlier conversation we were having as well on telehealth. Our folks are very, very supportive of ongoing telehealth, regulatory flexibility and support for telehealth. However, I have to note that during the past year, it was at times really challenging for all children to benefit from behavioral health services through telehealth modalities. The digital divide, of course, which we've heard about and discussed, is huge. For low-income families, it's not just access to broadband, which is a problem in many parts of the state, or devices, which is also a problem for many low-income families, but it's also other things that folks may not think about, like, do you have a private space in your home where you can engage confidentially in a therapeutic intervention? Are there, you know, if you're living in a home and there are a lot of other family members there, or it's a smaller home, you just may have nowhere to go actually to get that help. And then our clinicians were amazing about adapting their children's services to telehealth modalities. We actually sought outside help from foundations to fund, you know, some really fast collective learning on how to do that. But we found that while many kids in this generation are of course adept at using tech for school or for fun, when it comes to addressing their behavioral health needs, especially for our more acute needs children who need more sustained, regular, or longer telehealth visits, we're not seeing that telehealth is a substitute for some of our more high needs youth. And some children, they just don't want to engage through telehealth for this particular purpose. And so we really are going to have to look to the workforce and in-person services as a big part of this. So where do we go from here? If we can go to the next slide, please. Based on the experience of county behavioral health in providing EPSDT school-based services and arranging and delivering crisis services for children and youth, we would ask the Commission to consider the following recommendations. One, on CalAIM reforms. The state's CalAIM reforms promise to ensure not only that more children and youth have access to specialty behavioral health services, but that policymakers can more accurately capture the work of county behavioral health in serving these communities. We're spending way too many of our MHSA dollars on serving these populations without matching funds. I'll say of the roughly $2 billion counties get a year in MHSA funds, we're able to leverage about half of that with Medi-Cal federal financial participation. It's a huge part of our Medi-Cal services, and we think that that could grow under CalAIM. In addition, we really hope to move away from the unnecessary state-imposed fiscal audit liabilities and challenges for policy providers and our clients, and we really hope that a new day is coming in terms of that. As I mentioned, expanding our school-based partnerships, we believe will be key. And, we support the governor's proposal of incentive payments through managed care plans to expand on these partnerships. However, because of the more comprehensive services we deliver, we think that the smartest way to approach this is to invest in county behavioral health. And so we really also are supportive of the efforts to expand on the Mental Health Services Act OAC grants to do this. And again, would love to see our ability to get reimbursement from commercial plans be moved forward. On statewide transparency and accountability issues, we agree with all of the comments that we need to look comprehensively and more statewide across the different delivery systems and funding streams. And so CBHDA is co-sponsoring AB 686 with the CPEN and the CBHA. This is modeled after similar outcomes and accountability legislation, which was implemented for our child welfare and CalWorks programs. And, currently counties have many different regulators across different state departments and agencies. We provide hundreds of pages of reports to the state on an annual basis in keeping with those state and federal requirements. But from our perspective, the issue is that there really isn't a consolidation of those reports or really any way to look across at a defined set of outcome indicators. And so our bill would help to set that process up and also evaluate and create targets for reduction of disparities across different populations. Pulling up to the state level across county behavioral health programs is so important, again, because of the varied state regulators that we have. We believe that, for example, the OAC does a fantastic job on reporting on Mental Health Services Act funded programs, but they lack the Medi-Cal or substance use disorder or sometimes the clinical expertise to adequately reflect program outcomes in the aggregate across all our programs. And really, we are touching so many different systems. The governor's budget also included a significant allocation of $750 million in one-time funds to support the build out of community-based county behavioral health infrastructure. This funding is intended to address systemic gaps which result from the limitations on the way that we've been reimbursed through Medi-Cal. We're limited at cost. We don't get any money above cost from Medi-Cal. And so this funding is critical. And with yesterday's announcement from the governor, we are actually poised to potentially receive $250 million more in infrastructure investment that is focused uniquely on the needs of children and youth in Medi-Cal, which is tremendous. Our next statewide priority is also addressed through the governor's announcement yesterday, and that has to do with workforce, a theme which has come up over and over. And I think it's really important to note, again, on this theme of statewide coordination and leadership, if we put a ton more resources into behavioral health services at schools, but we don't do this in a coordinated way, one of our concerns is that we're really just going to be shifting workforce from one place to another, taking away from one system and recruiting into another. We need to grow the pot in the aggregate. We need to add to our workforce across the various systems trying to serve children. And we also face very unique challenges in recruitment and retention into rural communities. And we face significant challenges with the pipeline and making sure that we have a diverse workforce, which is where some of that investment in peers is so important. Overall, as you likely have drawn from my presentation, we believe that our behavioral health public safety net is significantly underfunded. We need to recall that part of the reason why we have a realignment-based structure was to protect funds in the behavioral health safety net from the Prop 98 funding guarantee. However, currently, our reimbursement is not tied to the number of Medi-Cal eligibles or whole population that we serve. And our funding has not really kept up with demand for services over time. And this is a really significant problem. I will highlight for you, for example, that our 1991 realignment funding levels for fiscal year 21-22 are in real numbers, not even adjusted for inflation, below the amount that we received in fiscal year 2004-05. We rely on 1991 realignment as a core funding source for all of the IMD levels of care. That's the most expensive care that we provide, along with our state hospitals, our justice-involved populations, et cetera. And so, you know, that funding source obviously is a real challenge for us. And in terms of our 2011 realignment, which covers EPSDT as part of that, by our estimates, it only covers about 65% of our match that we need to put up for the EPSDT entitlement as a whole. And so that's where you see counties making up the difference through our MHSA funds, which means that, you know, those MHSA dollars could be spent elsewhere, but we're really needing to lean hard on that revenue stream to put up non-federal share. So in all, I just want to thank the Commission for the opportunity to speak to the really timely and important issue of children's behavioral health needs. And we really appreciate the interest of the Commission in this topic and how we can work together to address the needs of children and youth moving forward.
Thank you. Thank you very much for your detailed testimony, your written testimony, and the identification of the recommendations that you've done, that you laid out in the document, and for giving us the perspective from the county level, which is extremely important. Let me turn this back to Ethan. I'm wondering whether or not we have any public comment.
Thank you, Mr. Chairman. We'll move to that portion of the agenda, and if the staff can put the directions for public comment back up on the screen, please. If you have called into the meeting, please email us immediately at littlehoover@lhc.ca.gov if you wish to make public comment. Do that now. Include your name and the phone number from which you are calling so that we know who to unmute if you're called on. You may also use the raised hand feature in Zoom if you have public comment. Public comment per the Commission's usual proceeding is limited to 3 minutes per commenter. I'm aware we have no raised hands, I believe. Rachel, can you let me know if we have any emails of people wishing to make public comment?
We have not received any emails.
Mr. Chairman, I think then we can actually move on from.
Oh, sorry, we just had one hand pop up and then it disappeared. So continue.
Okay. I think that's fine. Mr. Chairman, I think we can close public comment and finish and complete the agenda.
Thank you I want to thank you. I want to thank all the witnesses for their testimony. Thank the commissioners for their participation. We'll conclude this meeting, and though I think, Ethan, you've got a couple of things to remind us of.
I do, Mr. Chairman. The next meeting will be in 2 weeks, and Rachel, you may go ahead and take down the directions on public comment. So the next meeting, Mr. Chairman, will be in 2 weeks on the 27th at 10 a.m. our usual time. And as you mentioned earlier, we have an excellent lineup. That will be the third hearing on this topic. Secretary Galley, Surgeon General Nadine Harris, and Toby Ewing, the director of the Prop 63 Commission. So look forward to that in 2 weeks.
All right, to all my commissioners, it was a pleasure to see you. Thank you for, again, your participation. Stay well, and we'll see each other soon.